Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 398 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. The next clinical case reads: TAD is a 70-year-old woman who retired from teaching 5 years ago. A few days ago, she noticed black, tarry, stools and was hospitalized for an upper gastrointestinal bleed, most likely secondary to non-steroidal anti-inflammatory drug use. She complains of feeling tired and occasionally dizzy for about 1 week. TAD presents with a 5-year history of osteoarthritis for which she takes naproxen 250 mg in the morning and 500 mg in the evening. When questioned, she denies the use of corticosteroids, bisphosphonates, anticoagulants, clopidogrel, or a selective serotonin reuptake inhibitor, abbreviated as SSRI. She did not have a history of a previous ulcer or related complication. Other medications include hydrochlorothiazide 25 mg daily and lisinopril 20 mg daily for hypertension, self-directed treatment with enteric-coated aspirin 81 mg daily, calcium carbonate, and a multivitamin. TAD does not use tobacco or drink caffeinated beverages, but does have an occasional glass of wine. She denies epigastric pain, nausea, vomiting, anorexia, and weight loss, but notes a recent change in stool color. A review of other body systems is non-contributory other than previously indicated. There are no known food or drug allergies. Physical examination reveals a well-developed weak woman in no acute distress. The abdomen was normal with no pain on palpation. Bowel sounds were normal with no guarding, masses, hepatomegaly, or splenomegaly. The rectum was normal but with guaiac-positive stool. Vital signs include a temperature of 98.9 degrees Fahrenheit, blood pressure of 100 systolic 65 diastolic, and a heart rate of 90 beats per minute. Pertinent laboratory values include the following: hemoglobin of 11.0 grams per deciliter, a hematocrit of 35%, blood urea nitrogen, abbreviated as BUN, of 40 mg per deciliter, and serum creatinine, abbreviated as SCR, of 1.5 mg per deciliter. All other laboratory values are within normal limits. So my question to you is, what factors placed TAD at increased risk for experiencing a non-steroidal anti-inflammatory drug-induced ulcer and related upper gastrointestinal bleeding? The use of non-selective non-steroidal anti-inflammatory drugs, e.g., naproxen, is linked through a threefold to fourfold increase in upper gastrointestinal complications, and there is a twofold to threefold increase with COX-2 inhibitors when partially and highly selective agents are evaluated as a group. The risk for upper gastrointestinal events occur at any dosage, including low doses of over-the-counter non-steroidal anti-inflammatory drugs, and can occur at any time during treatment. TAD's self-treatment with cardioprotective dosages, that is, 81 to 325 mg per day, of aspirin in combination with a non-steroidal anti-inflammatory drugs, e.g. naproxen, increases her risk of upper gastrointestinal events to a greater extent than the use of either drug alone. The use of buffered or enteric-coated aspirin does not confer added protection from ulcer or upper gastrointestinal complications. TAD's age, that is 70 years, is an independent risk factor for non-steroidal anti-inflammatory drug-induced ulcers, because risk increases with the age of the patient. The increased incidence in older patients may be explained by age-related changes in gastric mucosal defense. Although TAD did not have a history of an ulcer or ulcer-related complication before admission, a history of a non-steroidal anti-inflammatory drug-related upper gastrointestinal event further increases the risk of non-steroidal anti-inflammatory drug-related gastrointestinal injury. Corticosteroids do not increase the ulcer risk when used alone, but the risk is increased twofold in corticosteroid users who are also taking concurrent non-steroidal anti-inflammatory drugs. The risk of upper gastrointestinal bleeding is markedly increased when non-steroidal anti-inflammatory drugs are taken with anticoagulants, bisphosphonates, or antiplatelet medications such as clopidogrel. SSRIs independently increase the risk of upper gastrointestinal bleeding, and although the magnitude of the risk is variable, it is increased in patients taking non-steroidal anti-inflammatory drugs. The pharmacologic mechanism underlying this adverse effect is thought to be related to SSRI inhibition of platelet aggregation, which may interfere with ulcer healing, but it remains unknown if SSRIs have a direct ulcerogenic effect. It is uncertain whether Helicobacter pylori is a risk factor for non-steroidal anti-inflammatory drug-induced ulcers, but a higher incidence of peptic ulcer disease in Helicobacter pylori-positive patients taking non-steroidal anti-inflammatory drugs suggests an additive effect, which may increase the risk of non-steroidal anti-inflammatory drug-related gastrointestinal complications. TAD's multiple risk factors convey an increased risk for a non-steroidal anti-inflammatory drug-related upper gastrointestinal event. TAD was admitted for further evaluation and treatment. An esophagogastroduodenoscopy revealed 2 bleeding antral ulcers, that is 0.2 and 0.4 cm, and endoscopic hemostasis was performed. An antral biopsy was reported to be Helicobacter pylori negative. All medications were discontinued before endoscopy. Oral oxycodone was instituted after endoscopy at 5 mg every 6 hours when needed to control TAD's arthritic pain while she was hospitalized. Consideration was given to decreasing the naproxen dose and switching to acetaminophen, a non-acetylated salicylate, or a partially selective non-steroidal anti-inflammatory drug, but none of these options were satisfactory for this patient. Treatment was initiated with a continuous infusion of IV pantoprazole for 3 days, and then switched to oral pantoprazole 40 mg twice a day. TAD was discharged on pantoprazole 40 mg daily and naproxen 250 mg in the morning and 500 mg in the evening. Hydrochlorothiazide, lisinopril, calcium carbonate, and the multivitamin were reinstituted upon discharge from the hospital. So my question to you reads: will TAD's gastric ulcer heal if she continues to take the naproxen? The naproxen should be discontinued, if possible, in the presence of an active ulcer. If the non-steroidal anti-inflammatory drug was discontinued and TAD's treatment was continued with alternative therapy such as oxycodone, a proton pump inhibitor is the preferred treatment to heal the ulcer because it provides a more rapid rate of ulcer healing, that is 4 weeks, and symptom relief than a histamine 2 receptor antagonist or sucralfate, for 6 to 8 weeks. Because the naproxen was reinstituted at discharge in the presence of an active ulcer, a proton pump inhibitor is the drug of choice, because potent acid suppression is required to heal the ulcer and relieve the symptoms. The duration of proton pump inhibitor therapy should be extended from 4 weeks to 8 to 12 weeks, as continuing the offending non-steroidal anti-inflammatory drug will interfere with ulcer healing. Cardiovascular risk and the need for low-dose aspirin must be determined by the patient's primary care physician or cardiologist, and if not needed, the aspirin should be discontinued. However, low-dose aspirin should be continued after endoscopic hemostasis in patients at cardiovascular risk. Clopidogrel should not be substituted for low-dose aspirin in order to reduce gastrointestinal bleeding. The next question reads: which ulcer healing regimen would be recommended if TAD was reported to be Helicobacter pylori positive? All patients with non-steroidal anti-inflammatory drug-induced gastrointestinal events should be tested for Helicobacter pylori. A proton pump inhibitor-based eradication regimen is recommended in a Helicobacter pylori positive patient with an active ulcer who is also taking a non-steroidal anti-inflammatory drug. One reason for this is that it is not possible to determine whether the Helicobacter pylori, the non-steroidal anti-inflammatory drug, or both actually caused the ulcer. If an individual is tested and found to be Helicobacter pylori positive, he or she should be offered eradication therapy whether or not there is a documented ulcer. The selection of a specific regimen depends on a number of factors, including whether the individual is allergic to penicillin. 3 months later, TAD returned to her gastroenterologist for a follow-up esophago-gastroduodenoscopy, which confirmed that the gastric ulcers were healed. On return to her primary care physician, the pantoprazole was changed to famotidine 20 mg twice daily, and the patient was advised to discontinue low-dose aspirin. Current medications include naproxen 250 mg in the morning and 500 mg in the evening, hydrochlorothiazide 25 mg daily, lisinopril 20 mg daily, calcium carbonate, and multivitamins. My next question to you reads: what pharmacological options are available to reduce the risk of a non-steroidal anti-inflammatory drug ulcer now that TAD's initial ulcer is healed and she continues to take the naproxen? Strategies to reduce the risk of non-steroidal anti-inflammatory drug, including aspirin, ulcers and upper gastrointestinal complications include co-therapy with a proton pump inhibitor or misoprostol, the use of a COX-2 inhibitor, or various combinations of a proton pump inhibitor, misoprostol, and a COX-2 inhibitor. All proton pump inhibitors, when used in standard dosages, are effective for this indication. Standard histamine 2 receptor antagonist dosages should not be recommended as prophylactic co-therapy to reduce the risk of non-steroidal anti-inflammatory drug ulcers, because they are not effective in reducing the risk of gastric ulcer, which is the most common ulcer associated with non-steroidal anti-inflammatory drugs. Higher histamine 2 receptor antagonist dosages, e.g., famotidine with ibuprofen 26.6/800 mg 3 times a day, marketed as DUEXIS, reduce the risk of gastric and duodenal ulcer, but are less effective than a proton pump inhibitor. Famotidine 20 mg twice daily may be an alternative to a proton pump inhibitor in patients at risk who are taking low-dose aspirin, but comparative trials with proton pump inhibitors are needed to support the use of standard-dose histamine 2 receptor antagonists for this indication. There are no studies that have evaluated the use of histamine 2 receptor antagonists in reducing the risk of ulcer-related upper gastrointestinal complications. Histamine 2 receptor antagonists may be used when necessary to relieve non-steroidal anti-inflammatory drug-related dyspepsia. Misoprostol reduces the risk of non-steroidal anti-inflammatory drug-induced gastric and duodenal ulcers as well as the risk of upper gastrointestinal complications in high-risk patients. Initially, the recommended dosage was 200 micrograms 4 times a day, but diarrhea and abdominal cramping limited its use. A lower daily dosage of 600 micrograms per day should be used because it reduces gastrointestinal side effects and is comparable in efficacy. Dosage reductions to 400 micrograms per day or less minimize gastrointestinal side effects but compromise gastroprotective effects. When used as co-therapy, misoprostol and proton pump inhibitors have a similar efficacy in preventing gastric ulcer, but proton pump inhibitors have few side effects. A fixed dosage form containing misoprostol 200 micrograms and diclofenac 50 mg or 75 mg is available, but flexibility to individualize dosage is lost. Two large randomized, placebo-controlled, multi-center, clinical trials compared the gastrointestinal safety in patients taking COX-2 inhibitors with those taking non-selective and partially selective non-steroidal anti-inflammatory drugs and reported a reduction of 50% to 60% in upper gastrointestinal events with the COX-2 inhibitors. A 6-month trial, class, of celecoxib in patients who were not taking low-dose aspirin revealed a statistically lower rate of ulcer complications when compared with that of ibuprofen or diclofenac, but evaluation at 1 year found no gastrointestinal safety advantage among those taking celecoxib. This explains why celecoxib contains the same gastrointestinal warnings as the non-selective and partially selective non-steroidal anti-inflammatory drugs. In addition, a post-hoc analysis at 6 months indicated that patients taking celecoxib and concomitant cardioprotective doses of aspirin had a similar rate of upper gastrointestinal events as those taking either diclofenac or ibuprofen, thus negating the beneficial effects of celecoxib. Low-dose aspirin appears to have similar effects on other COX-2 inhibitors. TAD remains at high risk for another non-steroidal anti-inflammatory drug-related complication even though gastric ulcer healing was confirmed, because she continues to take naproxen. Co-therapy with a proton pump inhibitor or misoprostol is preferred for this patient because both are effective in reducing the risk of non-steroidal anti-inflammatory drug-related upper gastrointestinal events. TAD's osteoarthritis is well controlled with naproxen, so there is no need to switch her to celecoxib or another more costly non-steroidal anti-inflammatory drug. Combining proton pump inhibitor therapy with misoprostol is not necessary, but some physicians prefer to use combination therapy for older patients with multiple risk factors. Standard histamine 2 receptor antagonist dosages, e.g., famotidine 20 mg twice daily, should not be used as prophylactic co-therapy for TAD, because they are not effective in reducing the risk of non-steroidal anti-inflammatory drugs-related gastric ulcer. Although higher histamine 2 receptor antagonist dosages, e.g., famotidine 40 mg twice daily, reduce the risk of gastric ulcer, they are less effective than a proton pump inhibitor. The famotidine should be discontinued, and prophylaxis should be instituted with a standard dose of a proton pump inhibitor, e.g., pantoprazole 40 mg daily. All proton pump inhibitors, when used in standard dosages, are effective for this indication, but TAD's out-of-pocket cost should be taken into consideration when selecting a proton pump inhibitor. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 399.